Welcome everybody to our November MHIDD Echo Session. I'll go through a few housekeeping things as we let other people in from our waiting room and let everybody get onto the Zoom link. Before we get started, if you'd be willing to put your name in the chat as well as your background, you're likely a support coordinator in a similar role, but it would be helpful for us if we could see a little bit about your background as you're joining the session today. This is our Fall 2024 series. It's been designed specifically with support coordinators and care or case managers in mind. Our topics were chosen by a group of support coordinators and a self-advocate. With that in mind, anyone is welcome to attend. So if any of our future sessions you think would be helpful to anyone that you know, feel free to share the information. We certainly won't turn anyone away. We have sessions scheduled out, 2 for December and 1 for January. I'll send out some information about those hopefully later today. That is all contingent on our presenters being able to present on those days and nothing surprising coming up with the holidays happening. Sometimes our schedule has to change. So if there are any changes to the schedule, you'll get an email from the system about that, and we'll make sure we keep you updated. These echo sessions are always recorded to make sure we improve where we need to improve and that we can provide them to people who registered but were unable to attend. So by attending today's session, you are consenting to be recorded, but you are welcome to leave the session at any time. We've been in the Zoom world for a while, but if you need help with any of the Zoom functionality pieces like renaming your profile, or the raise your hand functionality, shoot me a message. I can help you get those figured out. As usual, this is an echo session where we focus on how we can apply what we learn here to real life scenarios. So we often have conversations about real world situations. If you are talking about another person, avoid using their real first, middle, or last name, or any potential identifying information like address, contact information, family members, friends, etc. If you have a question about something you want to share and you're just not sure if it's identifiable or not, again, feel free to shoot me a message and I can help out with that. These echo sessions are intended to be interactive, especially when we have our case scenario discussion at the end. So we would appreciate each and every one of you attending today to find an opportunity to participate. Our case scenario at the end is best when we have full participation. So when we get to that point, I'll ask you to unmute or turn on your camera if you can, and we will hopefully have an engaging group discussion. We will start out with our didactic presentation. We are super fortunate to have Dr. Kristal James with us today. And then we will close with a case scenario discussion / presentation. If in the future you have any case scenarios that you would like input on from this group, you are welcome to submit them to me. My email is rachel.byers@usu.edu. I will also drop that in the chat. This is an opportunity for you to get feedback from your fellow professionals and peers if you have a tricky situation that you're dealing with. We do offer CEUs through the Utah Social Work Association for this series. We also have certificates of attendance if you don't need a CEU from the USWA but still want proof of attendance. To get either of those, you'll need to fill out the survey link at the end of the session, and I will drop that in the chat at multiple points to make sure you have plenty of opportunities to fill that out. If you are here, you likely have an account with iEcho, but that is how we run these sessions and where you can get access to all of the content. If you have any questions about the iEcho platform or the Echo series in general, feel free again to shoot me an email. And lastly, we do have social media pages where we share information about this Echo series as well as the other Echo sessions that we have going on at the Institute for Disability Research, Policy, and Practice. So This QR code will take you to our social media, or you can use our handles here, and you can learn about other Echo programs we have going on that you may be interested in. Our next session is planned for December 2nd, and it will focus on collaborating with mental health professionals and advocating for individuals who are in inpatient mental health settings. I will send out information about this session later today. And again, ask any questions to me if you have them. So today, as I said, we are super fortunate to have Dr. Kristal James here presenting. She has been teaching in higher education since 2009 and is a licensed clinical mental health counselor in the state of Utah, a nationally certified counselor, an approved clinical supervisor, and a board-certified telemental health provider. She has served as the president and graduate student and emerging professionals chair for the Utah Mental Health Counselors Association and is currently serving as the past president and treasurer. She also has a private practice providing telemental health counseling services to students grades K through 12 who qualify for individual education programs or IEPs. Her clientele consists of a variety of clients, including those diagnosed with IDD, autism, anxiety, and depression. She loves to network, collaborate, and continue to learn from colleagues in the community. And Kristal, I will turn it over to you. You're welcome to add to that introduction.
Oh, that's great. Thank you. I have nothing else to add. But welcome, everybody. I'm excited to be here, and I appreciate the invitation, Rachel, so thank you very much. I'd like to take just a minute to get to know all of you just a little bit better. I know that we don't have a whole lot of people here. There are very few of you here, so I think we could take just a minute to get to know all of you, and I'd like to hear what you hope to get out of today's session. Anybody willing to share? You can type it or you can unmute.
I'll go ahead and share. Hi, my name is Hope. I am a case manager for the DD waiver here in Sheridan, Wyoming. I'm fairly new, so I'm hoping to just soak in as much information as possible. So
Great.
Thanks for having me.
Thank you. Anybody else?
I'll go ahead and go here. Let me go on video while I talk. I was eating some lunch, so I apologize. So I'm an external support coordinator in Utah, and I have a lot of clients with comorbidity of mental illness that I feel I'm prepared in many ways. So I'm hoping to just get some additional knowledge to better serve them.
Thank you. Thanks. I appreciate that.
Hi, I'm Laura, and I'm on the forensic civil commitment team with the SPD. And I also have a lot of people who have dual diagnoses. So I'm anxious to learn whatever I can.
Excellent. Thank you. And then I see in the chat that I support my clients with mental health concerns. Thank you. Well, I appreciate those of you who are willing to share. It's nice to meet all of you. It sounds like there are several of you who, that are new and are trying to learn just as much as you can, but then also some that are probably pretty seasoned. And either way, it sounds like you probably are faced, if my suspicions are right, even if you are well seasoned, you probably are faced with new things every day that might surprise you. So my goal today is to really kind of go into a little bit more about crisis prevention. So kind of going back to what happens, what do we do when we work with a client that we maybe catches us off guard, or we feel like we aren't prepared, or any other kind of crisis intervention or crisis prevention, anything that kind of jumps out at us when we're working with clients that we were maybe unprepared for. So We'll first define crisis, then we're going to discuss the prevalence and then understand the meaning of client statements. So the very first slide here is I'd like to have a brief discussion about what crisis looks like. What does it look like for you in your work and in your experience? And again, same thing, you guys can unmute or you can put it in the chat.
Do you mean to have some slides up right now?
Oh, am I not sharing? I apologize.
Oh,
Thank you.
you're fine.
Uh-huh. Thank you. Can you guys all see that? Thank you. Okay, so what does it mean? What does crisis look like for all of you?
I'll share a
Yeah.
little bit. So I didn't provide this background at the beginning, and some of you guys may know this if you've been to a previous Echo session in this series. But before working at the IDRPP, I worked in disability services. I was managing residential rehabilitation services, and we ran into, I would say, many crisis situations. But one thing that stood out to me is crisis looked like panic and uncertainty. Those are two words that come to my mind.
Yeah. Okay, so panic and uncertainty from your clients.
Mm-hmm.
Yeah, thank you. I saw somebody else. Yeah, thanks.
I feel like when there's a crisis, it's like something nobody knows how to handle. And so they're coming to you like, oh my gosh, what do we do with this? We don't know where to go. We can't figure out what to do next. And it feels like there's a hurdle that we can't quite cross.
Yeah, thank you. So just for clarification, Marissa, I hope I said your name right. When you're saying that you like it's when somebody doesn't know what to do or how to handle it, are you talking about clients, your coworkers?
I feel like any time, like it could be anything. It could be my clients. It could be my support teams not knowing what to do with a client in a situation, or a coworker coming to me because they don't know what to do.
Mm-hmm. Yeah, thank you. Excellent. Thank you. And then in the chat, crisis can be different for each individual, but I think it's a point where people are unable to find their baseline or unable to calm themselves and need assistance to find balance. Yeah, very well said. So I really like that all of the things that you guys are talking about, it's this uncertainty. So yes, panic and uncertainty, nailed it. Yes, that's right. This panic and uncertainty. And sometimes I will say that crisis, sometimes it is that the client is in panic or has this feeling of uncertainty. And sometimes it's us, right? So Marissa, to your point, we don't know what to do. And so then all of a sudden we're feeling panic, we're feeling uncertainty. And so then all of a sudden we are in crisis. Hope, did you want to say something? Or were you just, okay, that's okay. Either way, I just want to make sure that I don't pass anybody over. Also, I forgot to mention this as well. If you guys have comments or questions, I know sometimes people like to wait till the end. Feel free to unmute or type in the chat. I do have the chat open, so I'll keep watching that as well. So feel free to do either, okay? But I really like what's been said, especially because sometimes we can feel panic and we can feel uncertainty, especially if we're seeing a behavior that we aren't used to, or if it's kind of an unexpected response to a situation. That can be cause for alarm, or it can definitely feel or look like crisis. But it looks very different for every person. So sometimes crisis is extreme, I mean, very extroverted, right? So there might be a lot of yelling and screaming, or kind of people getting really big and brave and strong, and they look really intimidating, and other people might not. So just like this picture is showing here, sometimes crisis can also look very subdued, and it can look very withdrawn. So crisis has many, many faces, but that's an important thing to just pinpoint, that somebody can be in crisis and might not be yelling. It doesn't always have to look like yelling. So this article right here, I'm not going to go into a lot of detail about it, but one of the things that was mentioned in this specific article was that individuals with intellectual and developmental disabilities disproportionately use emergency services. So that is significant. And the article goes into, you could read this article, and it goes into lots of different ways that you can kind of intervene when people are going into emergency services. But to me, the piece that was really important too is just this idea that people who have intellectual and developmental disabilities are disproportionately using emergency services, which means that perhaps we aren't intervening in our own role maybe as efficiently or effectively as we could be if it ends up meaning that they are using these emergency services. You know, it makes me kind of wonder, is it possible that with the right interventions up front, could we help reduce the number of emergency services that are being accessed? Thank you, Rachel, for posting that in there. So I have this picture of a horse just to kind of provide an image. And use this as an analogy. So when we are talking about people that are in crisis, if we see a horse that's kind of running around and is very spirited, sometimes we're trying to control, right? We want to control the situation. So again, I'm going to come back to that comment about panic and uncertainty. So if we are uncertain, we're trying to control the situation, right? So a lot of times we try to control the crisis to make it so that we feel more comfortable and we know what we're doing. When we come in with a lot of force, for example, sometimes it helps, right? We come in, we're problem solving, and we are able to give a lot of really good help and support to somebody immediately. But sometimes the opposite happens. If I go in to a horse and I'm kind of like trying to control this horse, if I'm not careful, if I'm not intentional about the way that I approach this animal, the animal could rear up on its hind legs, and it could become even more aggressive because I look like a threat to this horse. And so even when I'm trying to help control the horse or kind of trying to help keep the horse safe, if I'm not kind, or if I'm not aware of how to approach it, or if I come in pretty aggressive, again, that horse is going to have the opposite reaction, and I'm not going to be calming the horse down at all. I'm going to increase the crisis. And the same is actually also true when we're working with human beings. If we don't pause, and in crisis, that's like the last thing we think that we need to do or want to do. We are in a panic, and we want to kind of get over this hurdle as quickly as possible. And we want to overcome that barrier as quickly as possible. But if we do it, if we aren't careful, then we could also cause increased chaos. Now, I also want to say that that's not necessarily a terrible thing. I think it's a terrible thing if we do it on purpose, but sometimes we also don't necessarily recognize until it increases. But when we are patient through that process and we recognize that, oh, okay, well, maybe what I'm doing here is escalating the situation, then we have an opportunity to redo it. So I want to here's another terminology that's often used. Actually, this swimming upstream is kind of embedded in some curricula that's used often in school counseling with school counselors. And it's the idea that when we're working with people, and in their terminology, it's with students, if we swim upstream, which is the opposite thing that we think we should do, right? Like we want to kind of run away from the crisis, and we want to calm things down, which is also true. But what we have to be able to do, going back to that horse analogy, is we have to be able to approach the horse in a way that calms the horse. We can't just run away, and we can't just run up onto the horse. And so it's a matter of meeting our clients where they are, but also going in toward them. So we're going to be swimming upstream to kind of figure out what is wrong. All right. So this is this is kind of the meat of what we're going to be talking about today. This is called the Buckley model. And this is kind of guiding us in how do we approach that challenging situation. And let me back up just a little bit. So there is a client that drew a picture once for a clinician that I know. And the client had drawn a picture of a dog with its shackles kind of up, right? So, the reason she drew this dog in that way with the shackles kind of up is she said that this is how I feel as a client, right? Like that we're supposed, like that we're often mean and we're kind of prickly. And a lot of times when we see that happen, we might think, oh my goodness, what is happening? Our client is not grateful. I'm here trying to provide services, especially if you're a case manager, you probably have a wealth of knowledge. And our hope is that we are able to provide these services to clients. And we kind of expect, like, listen, like, how many of you guys have heard that phrase, don't bite the hand that feeds you? Have you guys heard that? Yeah. And sometimes as case managers, we might feel that way. Like, listen, I'm trying to help you, be nice to me. And the client who had drawn that picture of the dog also drew another zoomed out picture of that dog, and it showed that it had been in a trap, that the dog was actually in a trap. And so the client was trying to express that sometimes when I'm prickly, it's because I'm feeling trapped and I'm feeling like I'm stuck. So I then become in a panic, and I also become very uncertain myself. And so when we realize that as case managers or in any of our interactions, that our job is actually that we lean in to that pain, we lean into that point of resistance. It's a scary thing for us, but it's actually something that's by nature going to calm somebody down. So going back to this Buckley model, how Dr. Buckley recommends that we do this is that there are 3 areas that we're going to be reflecting for our client when we're communicating with them. And it's going to naturally guide us into that point of resistance or that trap, okay? And that is going to help us learn the importance of what is actually going on with our clients. So the reason that this is so important is because if we jump to problem solving too soon, we might be problem solving based on content, and then we completely miss the meaning. And if we miss the meaning, the chances are that the client is going to come right back in again. And so that, going back to that article that was posted in the chat here, that is one of my beliefs as to one of the potential reasons as to why clients will continue to seek emergency services at a higher rate. Sometimes it's because we haven't taken the time that we need in order to get to the meaning. And a lot of times we think, okay, well, that meaning, finding that meaning is going to take hours and hours. Sometimes it does if we want to get really deep into it, but that's also when you're going to refer them to a counselor, and the counselor can work on that with them. But what you can do at that initial point of content or contact with them is to figure out, what's happening, but also validating their feelings. So when we validate their feelings, immediately, if I'm seen and if I'm heard and if I'm understood, immediately I'm going to calm down. Because a lot of times what happens just by nature is we get bigger, we get louder when we aren't feeling heard. That emotion of just anger kind of gets really big. And then once we've been able to understand the content and label the feeling appropriately, really understand that feeling, then we're going to be more likely to understand the meaning. Okay. So questions about the Buckley model first, and I'm so curious to hear how realistic do you think it is to take time to find the meaning in your workplaces? I'd love to hear if you don't think that would work, or some of the barriers to doing that.
Can I just say, so I think this is helpful. But some of my challenges is actually finding resources to move on from the crisis. So, because we're limited with Medicaid. And so I know I've called many, many doctors. I've recommended many locations that won't take someone, or they have a long waiting list. So I think in that moment, it's nice to be able to, well, and I think my frustration and what I feel is an obstacle is I can talk them through, not, and really, and that's not necessarily my role, but I will be on the phone for a long time with somebody, just letting them get out these emotions. And then I try and find the resources, and I can't locate anything. And I'm certainly not going to ask them in a moment of feeling overwhelmed to make all those phone calls. So
Sure.
I know myself, I've made a lot of phone calls and still come up short. And that's just really difficult for me.
Yeah.
Because I feel like I can't help.
No, thank you, Valerie. I think that that's a really important barrier for us to discuss, truly, because I love, there are two things actually that I love that you said. One, that we need to, that this is where that transfer of crisis has shifted, right? So the client comes in crisis, talks to you. Now you're carrying and you're shouldering that crisis because you want to make sure that there's an outcome, but then like a positive outcome for them, a resource for them. And then I also really love that you say, and I don't know what to do. I don't even know what to do. And so how do I help the client know what to do if I'm stuck? So I'm curious to hear if anybody else has had similar situations or experiences, and if you have any comments first for Valerie before I share some things. Thank you, Valerie. Yeah, go ahead.
I have had several, actually. I have a client who came from DCFS, highly suicidal, and he has been my challenge since I've gotten him. And we've struggled to find people who want to take my client who's intellectually disabled and highly mentally ill. And so it's been hard. I feel the same way. Sometimes I don't even know where to go next because nobody wants to help us.
Yeah.
Nobody wants to take it on. So yeah.
I appreciate that. So resources are quite slim and you can't, so they come to you, which again might perpetuate some of that returning crisis because there's nobody willing to help.
Yeah.
Thank you, Marissa. And Hope, I saw you nod.
Right. I think even the crisis line often refers them to emergency services. So when you say there's an increase,
right.
I'm like, because a lot of us, that's really the only resource we know of that is available. So I can
that
see
has
where
to take them, right? So,
right.
I mean, like an emergency room will take them. And so you guys are bringing up some very, very important points. And it sounds to me like there needs to be several conversations that are had between clinicians and your services, like does that make sense, to make sure that people are feeling much more comfortable in working with clients who have dual diagnoses and some of the other challenges that you're seeing, because they are very unique, but especially the dual diagnoses, which I appreciate about the Echo sessions and the Echo curriculum, because I think that is trying to bring more awareness for sure. Yeah. And so Valerie, I'm sorry, I didn't mean to cut you off. Did you have anything else to say?
No, that was really it.
Okay. Yeah. Thank you. Others, what about anybody else? Okay, so it sounds like we've got a couple of thoughts, right? Well, we've got a long-term goal, which is to try to help bridge that gap. And then the short term is, what do I do though immediately when I have my clients with me? Because sometimes the emergency room is the best referral. And you know what? Honestly, Valerie, I also want to just say and clarify this. I do not think that it's inappropriate to send a client to the emergency room. Please hear that. I think that sometimes that is the most appropriate place for that referral. And I will say that the outcome is better. It's better when you send them to the emergency room, when you have been able to do exactly what it sounds like you're doing, which is validating and helping really understand what is happening. They're more likely to get better services when they go to the emergency room and be much more open to receiving those services when they go. So, because sometimes, I don't know if it has happened to any of you, but I've had to do a lot of work too with clients who sometimes they do need that emergency room service, but sometimes they are super resistant to go. And so by me taking this time up front, they're able to receive better care and more effective care when they get there. Anybody else have any comments about that? So Valerie, I just wanted to thank you for that comment too. And I wanted to clarify that I'm not suggesting that we shouldn't send them to the emergency room, because we should. Okay, but then I also wanted to say, I'm happy to stay after too. I'm sure that Rachel has some additional resources, and you guys all have those too. And you guys are probably very, very good at finding a lot of the resources. But I also know that a lot of the universities they have like clinics that are available. And I recognize that it's kind of a challenge too, to get universities to take on clients that are hard, because they're also working with their students. But again, I think if we're working on those collaborations, I think that it's also so important and valuable. And I've seen a lot of success when there is that collaboration that goes on, and schools are able to provide services while they're waiting to get into, on a wait list somewhere else or something like that. But at least it's an interim support. Okay, so here are some examples of just kind of I'm going to actually just share this example. So this one is a client that I have worked with, and the client came in and just said, I want to disappear. I want to disappear. And so when I was able to dig a little bit deeper, he did admit that he had suicidal ideation. So initially I might just say, okay, he needs to go to the emergency room. But I've worked with this particular client for about 7 years. And what I've also learned is that he doesn't always communicate in the way that is expected. And so when he says that I want to disappear or I am suicidal, what he actually is trying to communicate is that he feels like he's not belonging in society, and he doesn't want to harm society. And so this particular example, this was the most recent one, is that as he was trying to express suicidal ideation, he was actually talking about how embarrassed he is that he's hit puberty, and because of his disabilities, he doesn't understand how to navigate that. Now, this is also, though, where your referral might look different. Does that make sense? So right when he comes in, it might be a referral to an emergency room. And when I learned a little bit more, he actually doesn't necessarily need an emergency room. He actually needs additional support. Honestly, probably even some sex education on how to navigate puberty, which is very different. The emergency room is not going to provide that for him. So I'm curious to hear your thoughts about this specific example, or if it brings up any thoughts that you have in things that you guys are seeing. Valerie, I'd love to hear your thoughts about if you've seen something similar.
I have. I just felt like I was talking a lot.
No, I love it. It's great.
So it's one thing I think that is difficult to navigate is you want to take every possible suicidal ideation seriously. And I do have a client who is, he expresses this a lot, and often it really is frustration. And in my opinion, so puberty is, so I haven't necessarily seen puberty, but I have, for him, I believe it's, he hasn't been able to find his own voice. He's been told what to do a lot. So really the way we're navigating this is trying to help him better express his feelings, his needs, and his wants without telling him what we think those things are. So, and it is hard because you're like, I don't want to not get him intervention he needs, but we've been down the road enough. And I do think sometimes it's just time
That's
with
true.
the individual. Sometimes you know that about that individual, sometimes you don't, and you have to take it seriously. But
100%.
yeah, we've had enough experience with him. So, and speaking of puberty, he is somebody who wants a family someday. And so we've referred him to Tetons. That's actually a really good program right now in Utah to help.
Excellent.
But that's a hard one because parents don't really like that idea for a lot
That's
of
right.
my clients. So trying to sell that has been a challenge,
Yes.
but it's something they need to understand so much. And, you know, they're getting labels such as addicts, you know, that isn't really fair in my opinion. So I could probably go on about the dating thing and puberty.
It's so important. I actually love that you're having that conversation and that you're aware of that, because I recognize that there's, on the one hand, I mean, what we're going to probably identify by the end of this short presentation is how many gaps there are in services. And I would say that that is definitely one of them, because sex education that is just kind of embedded into the school systems, for example, is geared for a neurotypical child. And it's not, there isn't, at least my experience is that has been an area that is missed for clients that need, or students that need, a higher level of care, and that especially that have intellectual disabilities. And so I appreciate this ongoing conversation, Valerie. And you said a couple of things. One, you said time makes a difference, and it is true. So I also want to reiterate that even when clients are referred back again and again, and we see them often, I also think that that's, we don't necessarily need to look at that as a failure, that they continue to come back, because with every return, we learn more. And so then, Valerie, to your point, we're still limited, right, in what we're able to provide, how much time we have to be able to spend with them, you know, all those things were limited. And so I think it's also really important for us to be able to give ourselves self-compassion. You know, that's so important, that even though this client is coming back, it doesn't mean that it was a failure on my part. It simply means that I get to learn more. And not just you learning more, but also your client is learning more, because even about themselves with every interaction that they have with you. So very, very good point, Valerie. And I also love that you mentioned that sometimes it's just not being able to communicate what they're trying to, or not being understood. So yeah, thank you. Before I move on to the next slide, I'm curious if anybody has anything else that they would want to add to that. Okay. So Valerie, I know I'm coming back to you, but this is kind of another example of what you were just talking about. So again, another client, maybe I should just kill myself. The feeling, pretty simple, right? Anger. But what we learn about that anger is that what we were able to learn is that this particular individual just didn't like the family rules and didn't know how to express themselves. So similar to Valerie's client that was feeling controlled. That looks very, very different at that point. When you can learn that, when you can learn that there are differences in opinions, or I mean, when there are differences in how we're communicating, that when we know that, it allows us then to include the client in making decisions for themselves. And sometimes that's enough to help them calm down. But there are also times they don't have a choice. You know, that's one of those unfortunate pieces too, is that sometimes depending on behaviors or statements, the client doesn't have a choice, but when we can give them a choice, it's very, very helpful. I also just wanted to briefly talk about how do we get our client to communicate these things, because sometimes when we're just asking questions or when we're just reflecting, that works often, but there are some times that it still doesn't. So I want to also just back up and say that I learned early on in my career when I was working for a neurologist, a neuropsychologist, that people who have like TBIs, so mostly I was working with people who had TBIs in that specific setting, that when that occurs, the idea of a back and forth conversation is extremely complicated and complex. So he taught me early on to have them draw a picture for me. And if we can have them draw a picture, that slows the conversation down. And this is, again, if you're face to face, right? I mean, I even actually do it even in telehealth, but it's a little bit different in telehealth, the platform and how you have them draw pictures for you. But when I have them draw a picture, it slows the conversation down. And what that allows them to do is for them to kind of be able to keep up with the conversation because everything slows down. So if you think about it, when I'm having a conversation with you, I'm thinking about what I'm saying. And then if I'm listening to you, I'm listening to what you're saying, but I'm also trying to process it in a way that makes it all make sense, wrap it up in a nice little package, and then be able to communicate that back to you. That right there is a very, very complex skill. And a lot of people who have had TBIs really struggle with that part of it. They can listen just fine and they can communicate back, but sometimes there's that delay in process. Sometimes it's just an inability to listen and retain long enough to reply. There are a lot of things, like I said, that are going on. So this is an example of a picture that I had that a client drew for me when I asked, draw your family. Now, here's the fun part, in my opinion. When I've shown this drawing to people that are clinicians that are or getting their master's degree in clinical mental health counseling, or they want to be therapists, they immediately look at this picture and if they just interpret it right all on its own, this is the client right here. Okay, so it's a mom, a dad, siblings, and the client. They will often immediately look at this picture and interpret it for the client to say, oh, he must be feeling very insignificant or feeling less important than somebody else. How many of you guys, just by show of hand, you guys can put your little thing up. How many of you guys would think that when you're looking at this picture or had that thought? No, nobody? Oh, Valerie. Okay. Valerie did. Okay.
Oh, no, I think that's Rachel. Because I was like, mine was
that's
that
Rachel.
they ran out of room.
That's exactly right, Valerie. So I love that you said that because that's actually exactly what it was. Hope, was that yours too? You thought that they ran out of room?
Yeah. When I first saw that, I was like, oh no, they must feel very small and insignificant.
Okay. So you thought that maybe the insignificant. Yeah. So, and actually in learning more from the client, it was what Valerie said was that they had run out of room and they needed to fit inside the box. And the reason that I bring this up is because it just, again, we kind of get stuck on what words mean or what pictures mean. And if we assert our belief on to our clients, then we're more likely to miss the mark. So that is a tool. Hopefully that will help if you guys ever get stuck trying to understand. If you ever do get stuck trying to understand a client, I would encourage you to say, can you draw me a picture of what's happening? And I know that can feel very overwhelming and sometimes the client might get frustrated, but if we can just, again, slow the conversation down enough so that we can both make sure that we're understanding, it's a very powerful tool. Okay. So that is where I wanted to kind of just stop and give you guys an opportunity to practice, but it sounds like you guys have really good personal experiences and thoughts that you guys might like to discuss further. So before I do some practice, I'm curious to hear if anybody has some, I'm going to stop sharing this for a second. If you guys have any thoughts or comments or questions, just at the end of that.
Just one thought
Yeah.
that I had that has been really helpful for me is I do tend to, I often say their anxiety feeds my anxiety. And then I realize I am starting to scramble and fix without just taking a beat. And then I panic and I'm reaching out to everybody. So it kind of puts me in a state. So I think this has been really helpful to just kind of take a beat, even in that moment, to really consider what the next step should be.
Thank you. I couldn't see who was saying that, but I really appreciate your comment about this, that your anxiety or their anxiety feeds my anxiety. I think that we often look at that as, oh my goodness, I'm getting so worked up, or we can poo-poo ourselves for that. Like we can actually feel, we can shame ourselves for that kind of a response. But I also want to just point out that to me, that is evidence of empathy. And sometimes when here's the difference between empathy and advanced level empathy. Empathy is we get sucked in, right? So we now are we're part of we have empathy just along with them, and I'm feeling what they're feeling. Advanced level empathy is the ability to keep one foot on solid ground, meaning we are able to feel what they're feeling, but we can use that to our benefit. So actually, if you're feeling anxious and you're feeling like at a loss, let's just say that you're feeling trapped, or you're feeling like it's difficult to, like it just feels hopeless, right? The situation feels hopeless, or there aren't enough resources, or you're feeling like you're running out of options. I have no idea. I'm just making all of that up. But when you're aware of your emotions in that moment, and if you can reflect that back to the client, because chances are you're feeling that because that's how the client is feeling. And by validating it and saying it out loud, it also helps. It just gives it voice, so it doesn't have to be so big and loud like the horse in the beginning. So I'm curious to hear how that was being received. Who was that brought that comment, or that made that comment?
That was Valerie.
Okay, Valerie, thank you. Valerie, what are your thoughts about what I just said? It's okay if you disagree.
Oh no, I agree actually, because I do, because I never want anyone to feel unimportant. I know we probably all have a large caseload and you want to take that moment. But often I'm like, oh no, my whole day's plan now has been affected. And so I think recognizing that if I'm feeling that and being able to take that beat and know that the best way to help them feel important is to not start just trying to fix, and to take a minute to listen more actively, I'm going to be more effective in how I can help them.
Right. Thank you, Valerie, because it is true. Like you still might only have your 30 minutes or however long you get to spend with them, your hour with them. But when we do, just like you said, when we're able to validate and take that minute, our time with them becomes that much more effective. And we actually accomplish more by the end when we lean into that meaning in the beginning. And Hope, you said advocacy is a practice in empathy. And I think that's exactly why it is important to dive deeper with them to figure out the root cause. It's very true. Do you want to say anything else? I recognize that you put it in the chat because you might not want to say anything, but I'd love to hear you expound on that.
So
that is just something that has really stuck out with me since I started case management. Sometimes people just want you to listen. They feel alone and they don't, a lot of the times when people have providers or a big care team, it kind of is, it's like one person is saying one thing about their situation and another person is saying another thing about their situation. And I think what they really want and what they really feel kind of gets overlooked. And I think that that's why it is important to separate and just spend more time with them and getting to know like what that root cause is. Like, why are they feeling depressed? Why are they feeling alone? And I think that in that you can just really identify their needs.
Yeah.
So.
Thank you. I'm going to also say this, and then Rachel, I'll turn it over to you. But thank you so much for that, Hope. And it made me think of a comment. So that Dr. Buckley, in his Buckley model, he often says a phrase. He says, yeah, you're treating the client like an object to be managed instead of a human to be understood. And I think, Hope, that was exactly what you just described. And all of us are human beings and we want to be understood. And often the people that we work with, as has been mentioned already, a lot of times they come in and we unintentionally end up intervening with them as if they are objects to be managed instead of humans to be understood. So thank you. Thank you very much for that, Hope. Go ahead, Rachel.
I actually have a question for you,
Yeah.
Kristal.
Okay. Yes.
It's I feel like it's multi-part, but as I'm thinking about all of this, so support coordinators, I feel like I am not practicing as a support coordinator right now, so you guys can all please correct me if this is wrong, but I feel like support coordinators often get the short end of the stick, if that's the right way to say it, when dealing with crisis situations. And even in preparing or trying to prevent a crisis situation, because a disability service provider or a mental health provider working with someone will say, well, this isn't working, and just turn it back to the support coordinator.
Right. So it is kind of in your unofficial job description that you are the catch-all and responsible to fix it all.
Right.
Yes.
So as I'm thinking about this, I guess, are there concrete or specific action steps related to the Buckley model or that general approach that people can take as support coordinators to try and help prevent crisis situations? How would you sum that all up?
Yeah. So actually, I'll say this, that so the Buckley model, he does a lot of higher education, and he's actually he's training clinicians how to be clinicians. But here's the piece that I have noticed in my experience too, in training and also in working in the community, that sometimes when we're using these skills, it's one thing to use them for our client. That is true. That's an important thing. So to go back to your point, Rachel, about yeah, we are a catch-all, and I have to make sure that I'm meeting my client where they are and all of those things. But I've also used those same skills, the Buckley model specifically, when working with the person who's referring to me or referring the client. Because sometimes, and I've seen this specifically in the schools, because the schools are similar, where they want the counselors to fix the clients so that the students, so that they can get back to class, right? If the student is misbehaving in class or disrupting the learning environment in the school, then they want the counselor ends up being the fix-it. And I think that when we are using that Buckley model and we recognize that our ability to also understand the intention behind whoever's making the referral, that goes a long way too. Because sometimes the parents, if it's a parent who's seeking your help, it might be the parent is feeling frustrated. The parent is worried about the future, or the parent wants help. The parent doesn't know what to do, and the parent is at a loss. And so when we validate that and we take time to really lean into what is the meaning behind the referral too, not necessarily limited to what the client is saying, but what's the meaning in the referral? Do you see how that expands the use of the Buckley model to outside of just the client? Because again, otherwise we're doing the same thing that everybody else is, and we're treating the client. We are managing the client and actually making them kind of the scapegoat for everything else that's happening. And so when we apply that Buckley model and lean into the meaning of all things, we actually are indirectly helping our client. But it's a significant help. Does that help, Rachel?
Yeah, that makes sense. So if I'm understanding correctly, you can use the Buckley model from referral on, just getting at that deeper meaning behind the entire situation to help prevent crisis situations, but also if you find yourself in a crisis situation, finding more about what's really going on.
That's right. That's right. And sometimes, like, by just validating parent or employer or whoever's making these referrals, right? Validating them that this is difficult, it alleviates a lot of that pressure from them. And now all of a sudden they might be open to getting some help because they've been validated too. They might be getting help. Sometimes it's actually not about fixing the client. It's about getting support for the other people in their lives too. Yeah. Thank you, Rachel. That was a really good question.
I actually want to say, I think that's very true. And often it's hard as a support coordinator because you're having these conversations that aren't necessarily in your lane. And so what I'll often do is share my own experience with counseling and just say, it's really helpful for me to do this because I do find that often we're trying to fix, and I hate to say fix.
Yeah, I see the imaginary air quotes.
We're trying to address my client's needs, not realizing that it's a family dynamic need. And the one I was speaking about earlier, it's often after interactions with family that he feels frustrated. And I think it's because of that lack of voice. So that's something I've tried to do, but often you can't just go up to somebody and say, I think you all need there.
Right.
But truly, this is one person part of a group of people. And I do find that in most cases, they would all benefit because you just see them escalating each other in that communication. And you have to stand back and go, okay, I'm going to find support for this one person. And that's really not going to fix anything. It isn't. It doesn't fix everything. It can't.
No. Right. But even just that validation, just like you mentioned, that validation that this is hard and that we're running a marathon. This is a marathon, not a sprint, and it's hard. Sometimes that's just that validation might help somebody calm down enough to kind of quit trying to manage this other human being for a minute. Yeah, great point. Thank you. Thank you all. Okay, Rachel, I really appreciate it. And if you guys have additional questions or comments, post them in the chat. I'd be happy to keep answering them. But go ahead, Rachel.
Awesome. Thanks, Kristal. I'm going to share our case scenario slides. Make sure that you get those up. So this is a scenario from my time in disability services. All of the details have been changed to protect privacy, but this is a real world example. This case, as far as a little bit of background goes, let's say that you provide support coordination services for Adam, who is a 27-year-old male who really likes being outdoors, cars and trucks, and being with animals. So being engaged with his surroundings, especially things that he can work on that have engines, and also being with animals outside. He lives with his parents and 2 younger siblings. Some of his goals include working on strengthening his coping skills, sticking to his hygiene routine, and speaking positively about himself. He receives a total of 20 hours of supported living services from a local disability services agency per week. And recently, he's been struggling to strengthen his coping skills and build that general skill. He becomes very easily frustrated when his routine is disrupted. And something he tends to do when he becomes frustrated is to speak very negatively about himself. Our primary area of concern for this case is that one day you receive a phone call from Adam's disability service provider letting you know that there was an incident early in the day during his supported living services. When his parents asked him to help them with household chores, Adam became frustrated. The direct support professional staff began providing prompts to use his coping skills based on his program. Despite this, Adam continued to escalate and proceeded to grab a knife from the kitchen. He then told his parents and direct support staff that he would rather die than keep living like this. His parents called the police, who were able to help de-escalate the situation. But the disability service provider tells you they are concerned about Adam and that he needs a lot of help, quote, and they have asked if you think he should be transferred to a different disability service provider. The goals for this case scenario discussion are to determine what your role as the support coordinator is in this position, to determine whether Adam is experiencing a crisis based on what we know here, and then also direct Adam to the appropriate resources as needed. So we won't break out into any smaller groups because this is a relatively small group here today. But these are our community discussion points, and we'll just go through these questions one at a time, but I'm actually going to reverse our question order a little bit, and I want to start out with, have any of you experienced a similar scenario before?
Yes, I had a client, sorry, this is Julie talking. I had a client very similar to this, living with, mom and dad at home. And anytime he was almost asked to do anything, it escalated into an argument and him threatening, to hurt the parents and hurt whoever was in the room. Just like everyday kind of things, just it's time to shower, and it would just escalate to this kind of thing. So yes, I've had a client very similar to this.
Thanks, Julie.
I've also had similar. I had probably about a month ago even. He was living with a provider, and usually it would be if the provider asked him to clean up or something like that or participate in chores, would trigger him somehow. And it escalated to him getting aggressive and assaulting his provider and the police getting called, and then him having I think about a week and a half, he was at an inpatient mental health stay. So the provider did the right thing and calling to get help. And then ever since, he's been doing much better after getting the mental health stay help.
Thank you. I'm glad to hear he's doing better after getting some mental health help. But based on, those are just two examples from you guys. This is not a totally uncommon occurrence in disability services. There are lots of different crisis situations, but this is just one example I've given from my experience, but we saw scenarios like this frequently. So I know this is something that if you haven't run into as a support coordinator yet, you will likely run into something similar where a disability service provider kind of put their hands up like, I don't really know what to do at this point, or maybe they're stuck in a cycle of what they feel like is a crisis. So maybe they have a similar situation where someone like Adam will escalate to the point of the police being called, and then they settle down and there's no further action, there's no inpatient stay, but that continues to happen repeatedly. As a support coordinator, how would you guys describe your role in a situation like Adam's? Or for those of you who have had a similar experience, Julie and Iman, what did you guys do in response to that situation? How did the disability service provider interact with you? What did that look like?
I think just, continued conversations, you just kind of, in those moments, you're you're kind of constantly talking with each other, keeping that communication open between parents, between provider, between me, like how can we best help this individual? How can we support them? I mean, eventually it did take some time, but eventually it was just, we decided, you know, him living at home just was not the best place for him to be anymore. Mom's health played a factor in that too, because she had such fragile health, and then he was always like threatening to hurt her and different things. We just needed to get him out of the home, but that was a hard decision for mom and dad, because they had adopted him as a 16-month-old baby, and so they felt like, oh, we've just failed. But I'm like, but he's an adult, and no, you know, once what adult wants to continue living at home forever, you know, like it's just good for everyone. We need to have that relationship where he's an adult and out making his own decisions, but you can still support your adult children too. So anyway, that's kind of how we went about it. And he's done really well since leaving home and having a little more freedoms and things. He still doesn't like showering, and he still battles with his residential provider to do that. But it's, I don't know, he feels like he has a lot more freedom, and it's not that family relationship with mom and dad is much better, because he's an adult that lives he lives in residential, but he lives out of the house now. And so that their relationship was able to be salvaged just because the living situation changed.
Yeah, thanks for sharing. It sounds like, and I'm thinking about how to apply that Buckley model here. It sounds like getting to that meaning behind the situation, you were able to identify something that was contributing to stress and potentially contributing to crisis. And by changing that factor, you're able to make it so that while those things are still difficult, it's not as critical anymore.
Yeah. I was just finding the root cause, I guess you could say, that meaning, what's going on here really. So yeah.
And Kristal, did you want to explain where you got the Buckley model from? I just saw your comment.
Yeah, I just barely posted that. So I also just want to clarify briefly that with that Buckley model, so it's not like the Buckley model is, if you were to Google Buckley model, you can't find the Buckley model. This actually came from a man named Dr. Matthew Buckley, Matt Buckley. He goes by Matt Buckley, and he has just been a counselor educator for a couple of decades. And so it's how he has conceptualized all of the other evidence-based interventions and treatments and kind of simplified it into an easy thing to follow. So I just wanted to make sure that I didn't mislead anybody or think that I'm training you on some approach that's been very, very well researched. It hasn't, other than it's a compilation of all the other interventions that have been well researched. Thank you.
Thanks for clarifying. And one thing I have thought about after leaving disability services, I went back to school, got my Master of Public Health degree. And a lot of what I think about as someone with a background in public health, and I know that you all probably also have a similar perspective as support coordinators, is coming from a preventive place as often as we can instead of an intervention or interventive place, because it takes a lot more resources, a lot more time, and it's a lot more stressful for everyone involved once it reaches that crisis component. So I'm going to go back to the slide that's more descriptive so you can see what context was there. But what elements of this situation might point to crisis rather than just a frustrating day?
I'd say the police being called, the weapon, but then the police needing to be called to de-escalate.
Yeah, I think acknowledging that he is a danger to himself and those around him. I think immediately, I guess my My job as a support coordinator would be to just create a safe environment for him, whether that's removing him from the home and getting him some mental health services. And I think maybe long term, like I think Julie had mentioned, we could kind of look at maybe having him live on his own, maybe in the future, if he's capable of something like that.
Yeah, I think so.
I think, backing up even a step further to his frustration. I mean, I don't know if that was common, right? Was that common for him to get frustrated when asked to do household
Yes.
chores? Or
Yeah.
is this out of the norm, right? Like, is this something where it's like, oh, he's frustrated, and again, staff are like, okay, we're going to use your coping skills or whatever. And then at that point where he, continued to escalate and got the weapon or whatever, that's obviously a crisis situation. But I think like it could be identified sooner as just maybe his simple frustration. There's something underlying there that he's not able to communicate for whatever reason.
I'm curious, Kristal, as a licensed mental health practitioner, what are the red flags you would see in this scenario that would maybe
Yeah.
indicate that it's more crisis than just a moment of stress?
Yeah, so there are a couple of thoughts as I'm looking over your bullets. The first thought that I also have is like when we're talking about prevention, because the parents are calling the police. I know I'm not answering your question entirely here, but if the parents are calling the police, I'm wondering if this is their first encounter with the police or if this is an ongoing basis. And if it's an ongoing basis, are the police aware of him? And does he wear potentially like a medical alert that kind of explains some of the things, that he's dealing with? Because I'm curious if parents are calling the police because they're also worried. They're worried about what this could look like in the future, or are they in current danger? Does that make sense? Like,
Yeah.
are they trying to bring community? Are they trying to help the community understand him so that he'll be better able to navigate the community situation? Or are they calling him because they were truly threatened and worried for their lives? That's where my mind would go.
So, where a lot of times we face a crisis situation and then we have to figure out what to do after. What are the next steps? You're worried potentially about something like that happening again. So sometimes that fallout and follow-up can be really difficult. That can be, I think sometimes the hardest part is figuring out what next steps are. How would you approach addressing potential mental health concerns with Adam after this situation? Because we want to, and I should clarify, and as a broader principle, so the Echo series the project that this Echo series is a part of is about mental health and intellectual and developmental disabilities. And we have been trying to make it clear that in addressing these two, we aren't acting like they are one and the same. It's making sure that people get disability supports as they need them and mental health supports as they need them, and that we make sure that diagnostic overshadowing, or where those two are mingled and people aren't sure what's what, we want to make sure that we're avoiding that diagnostic overshadowing. So we want to address mental health as individual and making sure that it's fully taken care of, rather than being lumped in with disability or behaviors. So that clarifying piece there, how would you approach addressing potential mental health concerns with Adam after this situation? And Kristal, I saw your question in the chat. Adam in this scenario is 27 years old.
And what about his parents?
Age-wise, I would say late 40s.
Okay. Because it makes a difference, like if there's an opportunity to solicit help from Adult Protective Services.
I mean, I would say, if he doesn't already have a counselor or a therapist, mental health professional that he's talking to, then definitely getting him that would be a good first step. Referring him to his county's, mental health providers.
What about medication management? Like, do you guys refer maybe to the Polizzi clinic or something like that if they need assistance?
Yeah, I mean, I'd say, yeah, if he does have meds that he's on, do they need to be adjusted, or does he not? Or yeah, there's definitely, yeah, having him talk to his doctors about that as well.
Valerie, I see your hand raised.
Yeah, so that's what I do. I make sure they know where to go for mental health services and medication management if necessary. Sometimes an escalation of this, if they're on medication, is just an indication that they need a reevaluation. And then in Utah anyway, depending on how severe it is, then I'll mention the home program, which is our neurobehavioral program here in Utah. And if the family is too overwhelmed, I actually will make those phone calls on their behalf to start that process, because sometimes they're just not even in a place to be able to do that.
Thanks, Valerie.
Can I also, Rachel, I'm sorry, I just want to say one more thing about that. So Valerie, I also appreciate that you said that sometimes I have to make those phone calls on their behalf, because I know that there are a lot of people that I work with in the field that they will say, well, that just enables your client. You shouldn't be able to, you shouldn't do that. And I think the bigger thing is, it's true, we shouldn't do for our clients what they can do for themselves. But to your point, Valerie, if somebody's in crisis, they might not be able to do that for themselves in that moment. And I think that that's a really important distinction. So thanks.
Those are all the questions I had for this case scenario. Before we wrap up, do you guys have any other questions for Kristal while she's here? Do you have any other recent kind of crisis situations that you'd like some input on from your peers? Anything along those lines?
I just want to say, just express a huge, I just want to say thank you and express my appreciation for the work that you guys do, because it's really important. And I think it often gets overlooked. I mean, your day to day is often filled with crisis, and that wears on you. It wears on you, emotionally, physically, all of the things that it's just difficult. Sometimes we don't even recognize the amount of stress it's putting on ourselves or on our bodies until we take a moment and we step away. But I just want to thank you all for the hard work that you guys do, because it definitely takes a team of all of us working together in order to provide these supports. And it means a lot to me also, because I have I have professional experience with this, but I also have personal experience with it. And so I just think it's important to express my appreciation and thank you all.
I'll echo Kristal as well. I really appreciate everything you guys do in support coordinator positions. That care and case management piece is absolutely critical for making sure that people are connected with the services they need. I know of so many stories of I would say, success stories of people who had wonderful support coordinators, and it made all the difference in them being able to live the life they wanted to live. So appreciate you all. I'll hang out for just a couple more minutes. If you have questions for me or for Kristal, feel free to stay on and drop a question in the chat or unmute. Again, fill out the survey if you'd like a CEU from the USWA or if you'd like a certificate of attendance. Otherwise, we'll wrap up a few minutes early and I will send out information about our next session later today. Thank you, everyone.